Hey guys, welcome to another video. Today in topic discussion, I want to talk to you guys about diabetic foot infection. I know there's a video of mine that I talked about diabetic foot infection, but after a podiatry resident interview, I think I know a better way to present to you guys how to talk about diabetic foot infection. So for a resident interview, they are going to present this as it's a pretty typical case that they're going to present, and they're going to ask you to work up a case. Starting off, you see a picture like this shown in the slide. They say subjectively, they're going to provide you the subjective part. 57-year-old female patient comes to the ER with fever, states her right foot hurt worse than before. Diabetic, patient is diabetic, and she states it is controlled diabetes. They're going to ask you, what do you do next? So what you want to do is you want to finish up the subjective part. You want to go through the HPI, including the old card, the past medical history, including medications and allergies, past surgical history that is relevant to the foot, including previous history of amputation or irrigate INDs of the foot, because there is studies showcasing that it gets worse with a prior amputation, the prognosis, family history, social history, which is important, including drug use, alcohol abuse potentially, or whether or not what the patient does for day-to-day living to see if the patient can offload the foot potentially, and a review a system. And throughout the questioning, one important thing to remember is you want to see their blood sugar level and their recent A1C glucose level, because famous paper Inzuki stated that the blood glucose level elevating to 150 to 175 milligram per deciliter starts to impair your immune response. And that's important because if you fix up, irrigate, and you clean out the wound, whatever, the patient cannot heal and the patient cannot fight off the infection, then it's pointless to give them antibiotics and stuff like that. So understanding the blood sugar level is super important in diabetic foot infection case. Previous history of antibiotic treatment is also important to assess and ask the patient, because you have to know about resistance of the organism that's possible, and also what worked before. And if it worked before, you could also give the same treatment again. Tetanus status, literature showcased that 25% of diabetic foot infection can lead to a tetanus prone infection. And MPO status is obviously important because if the infection is severe enough, then you need to take the patient into surgery. So asking the MPO status is super important too. So one important thing to note is for a diabetic foot infection, controlling diabetes, the sugar level is important in a hospital setting. We've been taught that the sliding scale works, but the Inzuki also stated that rather than doing that, it's better to control basal metabolic insulin level by long-acting insulin like Lantus, and controlling after meal insulin level by rapid-acting insulin like Novolog. So after you do the subjective part, they're going to be like, okay, that's good. Now what do you want to do? Then you say you want to move into the objective part and start examining, starting with the vitals. Now the vitals is important, and the question that they can ask you is SIRS criteria. SIRS criteria, which is systemic inflammatory response syndrome. SIRS criteria include body temperature greater than 38 Celsius or less than 36 Celsius, heart rate greater than 90 beats per minute, rapid respiratory rate exceeding 20 breaths per minute, or the partial carbon dioxide pressure being less than 32 millimeter mercury, white blood count more than 12,000 or less than 4,000 per millimeter cube, or the presence of more than 10% immature neutrophil indicating, potential infection. So a different criteria other than SIRS criteria to assess patient state is a SOFA criteria, which is something more people are coming to use. Sequential organ failure assessment. And a quicker version, which is QSOFA, has three criteria, which is altered mental status, which is using the glycocoma scale, and a respiratory rate greater than 22, and a systolic blood pressure less than 100. So this includes the blood pressure, which is not included in the SIRS criteria. SIRS criteria includes, hypovolemic shock down the line when organ starts to fail. There's two types of criteria that are used to assess patient at that point, and the resident program may ask you about those things. So another thing to note at objective part is potentially they can ask you about the classic literature, Grayson and Lavery, which is Grayson stating that 89% positive predictive value of OM if it probes to bone, and 98% negative predictive value by Lavery's study if it also does not probe to bone. And I think podiatry community as a whole, general, kind of come to consensus that the Lavery's literature, which included I think more of an unbiased patient population with larger patient population size, is a better tool in our day-to-day practice. Another thing to note is diabetic patients are immunocompromised to start. So when they exhibit signs of constitutional symptoms of infection like fever and pain, that is a secondary sign indicating that they are in a pretty bad shape because they don't usually get those features. So what do you want to do next after the objective part of the examination? You're going to ask for labs and imaging. So what labs to order and what imaging to order is very important. Imaging is easy. You always want to order the basic radiograph, X-ray radiograph of the foot. Labs, the basic ones are CBC with differential, BNP basal metabolic panel. Some people argue you could also do a complete metabolic panel, which includes the albumin, bilirubin, and the liver function test and alkaline phosphatase. It could be a little bit more wasteful. People really debate about it, but you can't go wrong with BNP. So CBC with differential, BNPs, since it's diabetic, you want to order the glucose level, HbA1c level, coags including PT, PTT, INR, and obviously acute inflammatory markers to see if the patient is actually, in an acute inflammatory state, including ESR and CRP. One thing to note about ESR is that Coletta wrote a literature talking about more than 70 millimeter per hour of ESR value is kind of consistent with OM. Fletcher did a study where CRP value greater than 3.2, pretty sure 3.2, is also consistent with OM. So after you order the ESR and CRP, there are some optional, I think, personal opinion, lab orders that you could do. One thing is drug screening, and based on the social history that's provided, if the patient has a history of IV drug abuse or illicit drug use, then you want to order a drug screen to make sure there's no toxins that's going to interfere with your treatment plan. Also, this is also where you can mention to them that you could do a pre-op clearance, including EKG and chest x-rays, if the patient is likely to go to surgery. And pregnancy is another thing that you could also order if the patient is less than the age of female and less than the age of 50, again, for a surgical clearance. Culture is one other thing that you could get, and based on the IDSA guideline, you generally want to get it at 2 different sites after you clear out, irrigate and debride the area of the wound. Another thing that you could also order is non-invasive vascular studies. Those include ABI and Doppler ultrasound, ultra Doppler. And if the patient, especially with diabetic, if you have an ABI more than 1.3, I believe, then it's considered a calcified vessels. And if you have anything less than 9, you technically have a peripheral arterial disease. And depending on the severity, you will have a limb ischemia, and if less than 0.5, ABI is indicative of limb ischemia, and it would not heal properly. So after you say you want those labs and imaging, what they're going to do is they're going to give you the values. In this case, I just made up these numbers. The glucose is 180, which is elevated. You definitely worry about the immunocompromised state of the patient. CBC, you're going to see some neutrophil shift. ESR given here and the CRP given here. It's not always, ESR and CRP are sensitive, but they're not really specific in regards that they're not going to tell you much about the infection state. You have to go with other stuff too. So one thing they're gonna do is to read the radiograph in case workup. And people say you gotta prepare to do a formal reading, which includes like the ABC, which is alignment, bone density, cortices, and soft tissue. But in case of a diabetic foot infection, one thing you need to note is any bone resorption or cortical erosion because of the infection of the bone, soft tissue defect, and maybe like some bony alignments if there's anything. And if it has any gas gangrene or soft tissue emphysema, that's what you want to know. So in this case, if I were to read this radiograph, I would say a right foot non-weight bearing film of a skeletal mature patient with radial opacity at the plantar and dorsal surface of the forefoot, consistent with soft tissue emphysema, Defect of the soft tissue is also noted. Because of the clinical picture that I saw, I could say that. And you could go on to say that some sort of cortical erosion at the metatarsal of the forefoot is also noted, and that's it. That will be a focus exam, focus reading of the X-ray radiograph. So they're gonna say, okay, now what do you want to do? This is where you give them the assessment, and the assessment is basically, what you think the patient has, and you will say, 57-year-old female patient with a gas gangrene of the right foot, complicated by diabetes. And then they'll say, okay, now we went through the subjective, objective, and assessment part. You want to go to the plan, and they're gonna say, what do you want to do? So the first thing that should come out of your mouth is probably admit the patient, because gas gangrene is one of the emergent cases, one of the podiatry emergent cases. Quickly talking about when you're hospitalized and when you're not hospitalized. Outpatient care is basically if the diabetic foot infection is mild. Based on the guideline is the erythema less than 2 centimeters, patient is not really showing constitutional signs of infection, and the treatment plan can be done orally. If that's the case, then you could do a patient outpatient. But in this specific case, the patient has a gas gangrene, which is an emergent case, so you need to admit the patient. And other criteria to admit the patient is whether or not patient can follow a treatment protocol set by the physician. If it requires an IV antibiotics, you need to hospitalize, and it requires surgical intervention, which in this case it does, and an immunocompromised patient, which is in this case also complicated by diabetes, and probably it will have other disease, illnesses too. And also the social history of a patient can also dictate whether or not a patient could be admitted. If a patient is unable to offload because of the social history of the patient, then you can admit the patient. Say, for example, if the patient has to work or something, or is just in a bad, terrible environment residing in, then you can admit the patient. Common antibiotic treatments include the Zosyn combo, ciproclindamycin if there's a penicillin allergy, or I took it out from a slide that I was using here listing certain medications. So you can note from the mild to severe, the generation of the antibiotic increases. For example, mildly infected can be treated with Keflex, first-gen cephalosporin, clindamycin, Bactrim. Moderately infected wound can be treated with Bactrim again, with a little bit more levofloxacin, which is a surge, and quinolone. Zosyn comes in, Timentin comes in, a little bit more of a heavy hitter. And in severely infected wounds, it's going to be a combination of Zosyn, Premaxin, which is also a groveloid antibiotic, super strong, ciproclinda, levo plus clindamycin combination. On the slide over here, I also put the IDSA guideline of how to classify wounds. The way I look at it is uninfected is not infected, obviously, no redness, no any signs. Mildly infected, if it has erythema less than 2 centimeters. If you have purulence, you basically have an infection that you need to worry about in a diabetic patient, because especially in an immunocompromised state, patient having a purulent discharge will be consistent with moderate to severely infected state. So moving on to moderate is erythema greater than 2 centimeters, and then the difference between a severe and a moderate is the systemic signs of infection. So it lists like the search criteria, I believe, something similar to that included in here. So in this case, in this specific case, you say you want to admit the hospital, you want to admit the patient, and you want to do an obviously start with an antibiotic prophylactic treatment while you wait for the culture to come back, which is acquired after IND. You want to definitely irrigate and debris, and you could do it. If they ask you, okay, you call the attending and you say you want to do an IND, but the attending says, okay, I can't come in until Monday, what would you do? You probably want to say you want to do a bedside IND, meaning you're just going to cut it open, doing the bedside, clean it up, and then there's a packet, take a culture and then pack it. You could also take it to the OR. There, you could do the similar fashion of IND, make sure you get debris away, all the necrotic tissue. Depending on the case, sometimes if the wound is compromising the joint and all that, you could do a potentially amputation. So those are the options, surgical options available, but you want to make sure you combine that with the antibiotic treatment even after follow-up. So that's a general outline of how a case workup is done. If you guys have any questions, you guys can leave a comment below. Please let me know if I missed anything, and please remember to subscribe and tune in for our next video. I'm planning on doing more of these video of case workups. Thanks for watching this video, and really appreciate it. See you guys next time.